Welcome back to the deep dive. Today we're not just skimming the surface of medical research.
No, not at all.
We're delving into really the absolute core intellectual architecture that supports every diagnosis, every single intervention, and every public health policy you will ever encounter.
It's the foundation.
It is. We are discussing the foundational pillars of epidemiology: association, causation, and the pervasive problem of systematic error, or what we call bias.
And this deep dive is absolutely tailor-made for you as a future clinician. You really need to move beyond just, reciting definitions from a textbook.
Right.
You have to develop the framework that's necessary to critically dissect a research paper and determine, is this observed statistical link real? Is it distorted by some kind of error?
And the big question.
And most importantly, does exposure X truly cause disease Y? Mastering these concepts, it allows you to interpret evidence accurately, which is really the cornerstone of evidence-based medicine.
That's the mission. We have a stack of sources here, everything from classic texts like Park and Gordis, defining the fundamentals, to analyses of the gold standard Sir Austin Bradford Hill's criteria for causal inference.
So we need to walk through this logically.
Exactly. Let's start where all research starts, with the observation of a statistical link. Okay, so let's unpack that starting point. When we begin any study, whether it's looking at, say, diet and cancer, or air pollution and respiratory illness, we're looking for an association. What does that actually mean in mathematical terms?
At its most basic level, an association exists when two variables, and that's usually an exposure and a disease, occur together more often than we would expect them to occur by pure chance alone.
It's a statistical thing.
It's purely a statistical phenomenon. You're comparing the frequency of disease in an exposed group versus the frequency of disease in an unexposed group, or a comparison group.
I see. And the crucial mistake that everyone, and I mean everyone, even experienced media outlets, makes is confusing that statistical link with biological truth.
Precisely.
Yeah.
And this is noted in all the foundational texts. Association is a statistical relationship only. It's a signal in the data.
Just a signal.
That's it. Statistical association by itself does not necessarily imply causation. It simply means a link exists in your data, and that link is strong enough that it's worth exploring further.
So when we calculate an odds ratio or a relative risk, and it's greater than 1.0, suggesting a higher risk in the group that was exposed, that forces us into a fundamental process of critical thinking. What are the only four possibilities for why that statistical link showed up in our data?
This is, and you should think of it this way, this is the differential diagnosis for your research finding. It has to become second nature. When you see an association, there are only four, and they're not mutually exclusive explanations for it.
Okay.
One, it's real, meaning the exposure is truly causal. That's the goal.
Right.
Two, it's due to confounding. So a third variable is misleading the relationship. Three, it's due to bias, so a systematic error in how the study was conducted. And four, it's just due to chance, random error.
Which we usually try to rule out with p-values.
Exactly. And the entire subsequent process, designing the study, doing a rigorous analysis, thinking about causal inference, It's all dedicated to systematically eliminating options 2, 3, and 4.
So that hopefully only the first one is left.
That's the hope.
So to structure that elimination process, epidemiologists categorize these observed associations into three buckets based on what's actually driving the relationship. Let's start with the most insidious one. The spurious association.
The spurious or artifactual association, this is a false association. It's purely statistical, and it's fundamentally misleading because it is created entirely by a flaw in the study's execution.
A systematic error.
A systematic error, exactly. Particularly selection bias. The relationship you see is a statistical lie, really. It reflects poor measurement or bad sampling, not a biological reality.
Okay, so give us the classic essential example that really illustrates how selection bias can create a spurious link like that.
The prime example, and it's often cited in public health research, is the comparison of perinatal mortality rates. If you just analyze raw records, you might observe a statistically higher perinatal mortality rate in babies born in these, highly specialized hospitals compared to those born at home or in basic maternity clinics.
So if you're not careful, someone reading that data might spuriously conclude that hospitals are inherently less safe places to give birth than homes.
Exactly. But the association is completely artificial. And why? Because the patients who are self-selected or who get referred to these specialized hospitals are, by definition, the highest risk pregnancies.
The ones with preeclampsia, fetal distress.
All of it. complex maternal conditions, preterm labor. This differential selection, the selection bias, ensures that the two groups, the hospital births and the home births, they are just not comparable when it comes to their baseline risk.
So the association is there in the numbers, but it's not causal.
Not at all. It's generated purely by the mechanism of patient referral and risk stratification.
That's clear. So spurious equals false because of a systematic study error. Now the second type, the indirect or non-causal association, that feels a bit trickier because the statistical link is actually real, but the exposure isn't the true culprit.
Right. In an indirect association, the two variables are statistically linked, but the exposure you're studying, let's call it variable A, is merely a marker for the true underlying cause, which is variable C.
Ah, the confounder.
The confounder. Variable C explains the entire relationship.
This is where we get the examples of geography and disease prevalence.
A perfect example is the historical association between high altitude and endemic goiter. If you conduct a cross-sectional study, you will, without a doubt, find that people living at high altitudes have a statistically higher prevalence of goiter. The association exists.
But the altitude itself isn't causing the thyroid to hypertrophy.
Of course not. The true underlying cause, the confounder in this case, is iodine deficiency. High-altitude environments, particularly in mountainous regions, they often correlate very strongly with soil that has been leached of iodine. Therefore, high altitude is just a proxy, an indirect marker for the true cause, which is the iodine-poor environment and the subsequent nutritional deficiency.
So the statistical link is real, but the causal factor is external,
Precisely, making the altitude goiter link non-causal.
which means, intervening on altitude, say by moving populations, would be completely inefficient.
Right, whereas intervening on the true cause iodine supplementation would be incredibly effective.
And that brings us to the goal, the direct or causal association.
This is what we're looking for. The exposure genuinely contributes to the disease outcome. In this case, the statistical association aligns perfectly with the biological mechanism. The high odds ratios you find in case control studies linking smoking exposure to lung cancer, for example, demonstrate a powerful, reproducible, and direct relationship that isn't explained away by systematic error or confounding.
Okay, so before we move on from association, just a quick technical note. We rely on two primary statistics to quantify the magnitude of these links, the odds ratio and the relative risk.
Correct. The odds ratio, or OR, is predominantly calculated in retrospective case control studies. It compares the odds of exposure among the cases to the odds of exposure among the controls.
And an OR, significantly above 1.0, indicates a strong association.
Yes, it reflects how much more likely the diseased group was to have had the exposure compared to the non-diseased group.
And then the relative risk, or RR, is specific to prospective studies, so cohort studies and randomized controlled trials.
Right, the RR measures the incidence of disease in the exposed group relative to the incidence in the unexposed group. An RR of, say, 8.1, as we saw historically in smoking research, means the exposed population is 8.1 times more likely to develop the outcome than the unexposed population.
And the strength of that number, that's our first piece of evidence when we start to transition to the question of causation. So we've established the statistical link, the association. But we know that link could be a fluke, a systematic error, or just a marker for something else. Why must we devote so much effort moving past correlation to actually establishing causation in a clinical setting?
This is absolutely fundamental. Causation is the only justification for intervention.
The only one.
If you incorrectly assume that A causes B when in reality C causes B, your intervention that targets A is going to fail. It wastes public health resources, leads to harmful or just useless clinical advice, and often it diverts attention from the true problem.
And we have to look beyond just the p-value.
You must. We have to look beyond the statistical significance of p-values. A low p-value just means the association is unlikely to be due to chance. It tells you nothing about the presence of bias or confounding.
So if the stats don't give us the final answer, we need a conceptual framework for thinking about causality, especially when we're dealing with these complex non-infectious diseases.
Indeed, disease etiology is complex, and epidemiologists use models to organize that complexity. For simpler infectious diseases, we often rely on the classic agent-host-environment triad.
Right.
You have a specific pathogen, the agent, a susceptible person, the host, and the surrounding conditions, the environment. This is really useful for thinking about things like tuberculosis or malaria.
But the majority of the burden of disease today is chronic things like heart disease, diabetes, many cancers, the triad kind of falls short there.
It absolutely does. For chronic multifactorial diseases, we move to the web of causation. This model recognizes that a disease rarely has a single cause.
It's more complicated.
Much more. Instead, the outcome results from a complex mesh of interconnected factors: genetic, social, environmental, behavioral, all of them feeding into the pathological process. It forces us to acknowledge that just removing one strand of that web might not prevent the disease, because there are so many alternative causal pathways at play.
And to make the relationships within that web more mathematically concrete, we use the concepts of necessary, sufficient, and component causes. I always find Rothman's causal pi model incredibly useful for visualizing how multiple risk factors interact.
Rothman's model is excellent for MBBS students. A sufficient cause is a set of factors that, when they're all present, inevitably produces the disease. The complete pie is the sufficient cause.
Okay.
But that pie is made up of component causes. These are the individual factors that interact to complete the causal mechanism. No single component is usually enough on its own.
And the truly essential component in every single one of those pies is the necessary cause. The one component that must be present for the disease to occur at all.
Right. If the necessary cause is absent, the disease is impossible. For instance, the HIV virus is a necessary cause for AIDS.
But it's not sufficient on its own.
It's not sufficient. Other factors like host immunity, viral load, lack of treatment, those are required to complete the pie and cause the full clinical syndrome of AIDS. Understanding this helps us identify the most powerful point for an intervention.
So once we've organized all the variables using these models, we're finally ready to move to the framework that allows us to adjudicate causality.
The Bradford Hill criteria.
The Bradford Hill criteria, proposed by Sir Austin Bradford Hill back in 1965, are perhaps the most essential set of principles you're going to encounter in epidemiology.
So important.
It is vital to remember these are guiding principles for causal inference.
Not absolute rules.
They are not absolute mathematical proofs. They just help us systematically evaluate the likelihood that an observed association reflects a true causal relationship.
Okay, let's dedicate some time to each of the 9, starting with the one we can quantify. Strength of association. 1. Strength of association. As we just discussed, this is measured by the magnitude of the RR or the OR. The stronger the association, so the further the RR or OR is from 1.0, say an RR greater than 10, the less likely it is that the association is just explained away by some unmeasured confounder.
A huge effect size is hard to fake.
It is. It's a powerful piece of evidence suggesting the link is real. It's just very difficult for confounding alone to generate a huge, spurious risk.
Okay, next we move from the size of the finding to the stability of the finding.
Consistency.
Consistency. This demands that the findings are reproduced across different populations, in different geographical locations, and using different study methodologies.
So you see it again and again.
If the association between exposure X and disease Y holds true in a cohort study in Europe, a case-control study in Asia, and a time series analysis in North America, the cumulative evidence becomes incredibly compelling.
The link between smoking and cancer is the textbook example of consistency, right?
It's the absolute textbook example.
Okay, now for the most debated criterion, specificity. 3. Specificity. Historically, this criterion suggested that one cause leads only to one effect, or one effect results from only one cause. This was very relevant when dealing with infectious diseases and, Koch's postulates.
What?
But, and we must stress this, specificity is the weakest criterion and is often not applicable in modern chronic disease epidemiology.
So wait, if it's so weak, why do we even still include it in the framework?
Well, we include it for historical context, but also because when it is present, it provides incredibly strong evidence.
Right.
For instance, a specific occupational exposure might lead only to a very rare specific type of cancer. But for public health challenges like obesity, which leads to heart disease, diabetes, hypertension, and arthritis, a complete lack of specificity does not invalidate the causal link.
So the takeaway is you should never reject a causal hypothesis just because it lacks specificity.
Never.
Okay, let's move to the non-negotiable principle, the absolute requirement for causation, temporality.
4. Temporality. This is the one criterion that must be satisfied. The exposure must logically precede the onset of the disease.
It has to come first.
It has to come first. If you're studying whether a new drug causes liver failure, you have to confirm that the patient took the drug before the liver failure developed. If the study design, say a cross-sectional study, can't establish that time sequence, the causal inference fails instantly.
It's the ultimate hurdle.
It is.
Okay, so after we establish the sequence, we look at the amount. 5, biological gradient, or the dose-response relationship.
Right. If a relationship is truly causal, we would expect to see that increasing levels of exposure lead to a progressively greater risk of the disease.
More exposure, more disease.
Exactly. For instance, the risk of mesothelioma increases systematically with higher cumulative exposure to asbestos fibers. This dose-response effect is very convincing because it suggests a biological mechanism that's responding proportionally to the stimulus.
And it makes it harder to blame confounding.
Much harder, because confounding rarely follows such a neat increasing pattern.
Next, we integrate the finding with existing scientific knowledge. Plausibility.
6. Plausibility. The proposed causal mechanism should align with biological, physiological, or pathological knowledge that we have at the time. When the link between lead exposure and neurotoxicity was being studied, for example, the known properties of lead as a heavy metal aligned well with its observed neurological effects.
But this doesn't mean we just reject new ideas out of hand.
No, not at all, but those radically new theories require much more rigorous evidence if they initially lack that biological plausibility.
And then there's the slightly broader idea that ensures the finding fits within the larger picture.
Coherence.
Coherence. This basically asks if the causal conclusion is consistent with the known history and natural course of the disease. Does the epidemiological evidence fit with the clinical evidence, the lab findings, and the observed pathology?
Can you give an example?
Sure. If epidemiology suggests a chronic exposure causes a disease, but pathology shows the disease only develops rapidly after an acute exposure, well, the findings lack coherence. They don't fit together. Got it. Criterion 8 is about the highest form of evidence we can obtain. Experiment.
Experiment or intervention. If we suspect a factor is causal, the most powerful test is to intervene. If removing the exposure leads to a reduction in the disease incidence or severity, the causal hypothesis is strongly supported.
So a real-world test.
Exactly. Large-scale studies showing that switching to cleaner fuels reduces childhood asthma rates. That demonstrates the effectiveness of the intervention and supports the causal role of those airborne pollutants.
Finally, we use historical experience. Analogy.
9. Analogy. This suggests that if similar exposures are already known to cause similar effects, it makes a new finding more believable. The fact that many different types of inhaled particulate matter cause lung damage supports the analogous finding that a newly identified industrial aerosol also causes respiratory illness.
It leverages what we already know.
Precisely. It leverages accepted science to bolster a new claim.
So if we go back to smoking and lung cancer, it met nearly all of these criteria. A really strong association, massive consistency, undeniable temporality, a clear dose response, and plausible carcinogen mechanisms. That systematic evidence is what validated the causal inference.
Exactly right. Causation is rarely proved by one criterion or one study. It's established by the methodical accumulation of evidence across multiple domains, all rigorously checked against these 9 guiding principles.
But before we can even apply Hill's criteria, we have to deal with the errors that corrupt the very data we're trying to evaluate: biases.
Bias, as it's defined in our source material, is really the primary threat to the internal validity of any study. It is any systematic error in the determination of an association between an exposure and a disease.
And the word systematic is key here. This isn't just an occasional mistake.
No, not at all. Systematic means the error occurs consistently and predictably. It's always pushing the results in one direction, either artificially inflating the observed risk ratio away from 1.0 or artificially deflating it towards 1.0.
So the resulting estimate is just fundamentally inaccurate.
It is. And this is fundamentally different from random error.
How so?
Well, random error is due to unpredictable chance variation. It reduces the precision of your estimate, so it makes the confidence interval wider, but it doesn't really affect the accuracy or the direction of the estimate.
And we fight that with bigger sample sizes.
Right. We fight random error by increasing the sample size. We fight bias through superior study design and rigorous methodology. Once bias is built into your study, it's often irreversible.
So let's start with the errors that are introduced right at the recruitment stage. Selection bias.
Selection bias occurs when the study groups, the cases and controls, or the exposed and unexposed, are not truly comparable because of the way participants were selected or retained in the study.
The method of selection itself is the problem.
Yes, it's tied to both the exposure and the outcome, and that creates a distorted sample.
Okay, let's break down the 3 most common forms that future doctors really need to recognize. Let's start with Bergson's bias.
Bergson's bias is specific to studies where both cases and controls are drawn exclusively from a hospital population. Think of an investigation trying to find an association between factor A and factor B.
Okay.
If both factor A and factor B increase the likelihood of hospitalization, even if they have no biological relationship outside the hospital setting, you will find an artificially inflated association within that hospital data.
So if I were to study the association between, say, gallbladder disease and appendicitis, and I only recruit patients from the surgical wards, I might find a link just because both conditions independently drive people to the hospital.
Precisely. You are sampling from a non-representative high-risk subset of the population, which overrepresents people with multiple comorbidities or severe disease, and that inflates the observed association between two factors that might be completely unrelated in the general community.
Okay, the second classic example relates to population demographics, the healthy worker effect.
This is critical in occupational epidemiology. Working populations are, just by their nature, healthier than the general population because those with severe chronic illness can't work.
Right, they're selected out.
They are. So if you study an exposed cohort of healthy workers and you compare their outcomes, like cancer incidence, to the general population, which includes the sick, the very old, the chronically disabled, the workers will appear to have a lower risk simply because of their baseline health status.
And that phenomenon artificially deflates the true relative risk.
It biases the RR towards the null, towards 1.0, and makes the occupational hazard look less dangerous than it really is.
And finally, there's the problem of retention in long-term studies, loss to follow-up bias.
Loss to follow-up bias is a major concern in prospective cohort studies. This occurs if the dropouts are differential. That is, if the reasons for dropping out are related to both the exposure status and the eventual outcome.
Can you give an example of that?
Sure. Say in a study of an industrial solvent, the highly exposed workers who start feeling subtle symptoms are more likely to drop out, while the unexposed workers who drop out are just randomly healthy people. Your study then loses the sickest, most relevant individuals from the exposed group.
Which means the final reported disease incidence in that exposed group will be artificially low, again, deflating the risk estimate. So how do we prevent selection bias?
Prevention really involves rigorous design. You have to use random sampling methods to ensure your sample is representative, ensure very high retention rates, ideally 80 to 90% follow-up, and establish strict, objective, and uniform criteria for case and control selection before the study even begins.
So if type A, selection bias, is about who is in the study, type B, information bias, is about what is measured and how accurately it's recorded.
That's a perfect way to put it. Information bias, or measurement error, occurs when data on exposure or disease status are measured inaccurately or are measured differently between the study groups. This error impacts how we classify the subjects.
And the most common form we see in case control studies is recall bias.
Recall bias happens because the status of having the disease being a case affects the subject's ability or willingness to accurately remember past exposures. A mother whose child has a congenital heart defect is under immense pressure to find an explanation.
Of course.
And she will likely engage in highly detailed, anxious recall of every single antenatal exposure, her diet, medications, minor illnesses. A control mother, whose child is healthy, has no such pressure and will probably provide a less thorough, more general history.
So the case group appears to have a higher exposure prevalence than they truly did, which systematically inflates the observed association.
Exactly. Then we have biases that are introduced by the researchers themselves. Interviewer bias occurs if the interviewer knows the subject's status, case, or control, and then subtly alters their questioning technique.
They might probe a bit harder with the cases.
Right. If they believe a certain exposure is bad, they might probe the cases more aggressively to elicit that exposure history, leading to differential recording of the data.
And observer bias relates to outcome ascertainment.
Yes, often in prospective studies. If a researcher, say a radiologist or a pathologist, knows that a patient belongs to the exposed group, for example, they got the high dose of an experimental drug, that knowledge might unconsciously influence their objective interpretation of the outcome.
Like grading a side effect more or less severely.
Exactly.
Now let's solidify this overarching concept of misclassification bias, because this is the actual mechanical result of all this information error.
Right. Misclassification is simply the error of assigning a subject to the wrong exposure or outcome category. And we differentiate between two critical types because their impact on the results is entirely different.
Okay, so first, non-differential misclassification.
This occurs when the measurement error is random and it happens equally across all the study groups. For instance, if a faulty machine randomly records blood pressure incorrectly for 10% of the cases and 10% of the controls, this non-differential error tends to dilute the true association.
So it biases the result toward the null.
It biases your result toward the null, an RR or RR closer to 1.0, and while this makes it harder to find a statistically significant result, it reduces your power, it generally does not create a false positive association where one doesn't exist.
And the second type is differential misclassification.
This is the more problematic form. It occurs when the measurement error varies across the groups. For example, exposure is measured more accurately in the controls than in the cases, which is what happens in recall bias.
And this can distort the true association.
It can systematically distort the true association, potentially biasing the RR or RR either up or down, depending on the error pattern. Differential misclassification is a severe threat to study validity and can easily create spurious links.
So the fight against information bias really hinges on blinding and objectivity.
Prevention requires the utmost standardization. We use blinding, ideally double blinding, to ensure both the study subjects and the researchers are unaware of the exposure or outcome status. We use standardized, rigorous questionnaires, and whenever possible, we substitute subjective patient recall with objective measures.
Like medical records or lab tests.
Exactly. Medical records, validated lab tests, or biochemical markers. We reserved a dedicated section for confounding because, unlike selection or information biases, which are errors introduced by the investigator, confounding is a property of the variables themselves. It is a real third variable that distorts the observed relationship.
So a confounder is an extraneous factor that's associated with the exposure A and D, independently associated with the disease, and in doing so, it creates a false appearance of a causal link.
That definition is precise. And for a factor to qualify as a confounder, it must meet 3 absolutely strict criteria. You must memorize these.
I'll prompt you for them because I agree these are guaranteed exam questions.
Okay. First, the suspected confounder, let's call it C, must be associated with the exposure E. Second, the suspected confounder C must be an independent risk factor for the disease, D, regardless of the primary exposure, E.
And third,
And this is the most critical part for analytical distinction, the confounder, C, must not be in the direct causal pathway between the exposure, E, and the disease, D.
let's elaborate on that third point because this is where students often get confused between confounding and mediation. If the third variable is in the causal pathway, it's a mediator, not a confounder.
Excellent point. Let's consider the relationship. Obesity exposure leads to heart disease. If we introduce inflammation, say C-reactive protein, where does it fit?
Okay.
If obesity causes inflammation, which in turn causes heart disease, then inflammation is a mediator or an intervening variable. It's part of the mechanism.
And you should not adjust for a mediator.
You should not, because adjusting for it removes the very effect you're trying to measure.
But if obesity is associated with smoking, and smoking independently causes heart disease, then smoking is a confounder.
Exactly. Because it's not caused by obesity, yet it distorts the obesity-heart disease link. You must adjust for confounders like smoking to isolate the true, unconfounded effect of obesity.
And you should never adjust for mediators.
Never, or you'll mistakenly conclude the primary exposure has no effect. This is a vital distinction in causal modeling. And the common confounders you must always consider are age, sex, smoking status, and socioeconomic status, or SES.
The beauty of confounding, though, is that we have powerful ways to control for it, both in the study design phase and then later in the analysis phase.
Right. In the design stage, the gold standard is randomization, which we use in RCTs. By randomly allocating subjects, we ensure that both known and crucially unknown confounders are distributed equally between the groups.
Which neutralizes the threat.
It effectively neutralizes the confounding threat.
But for observational studies, where randomization isn't possible, we use restriction and matching.
Correct. Restriction involves limiting the study population to only those who share a certain characteristic of the confounder. For example, restricting a study to only females, thereby removing sex as a confounder. This simplifies the study, but it does limit its generalizability. Matching pairs a case with a control who shares the same level of the suspected confounder. For example, matching controls to cases based on age decade and ethnicity. While matching controls for confounding, it also introduces complexity in the analysis because you must use matched analysis methods.
And then, in the analysis stage, after all the data is collected, We have stratification and multivariable analysis.
Stratification involves analyzing the data separately within each level of the confounder. For example, calculating the odds ratio for the exposure disease link separately for men and for women.
Okay.
If the ORs are similar across those strata, but they're different from the crude, unadjusted OR, it confirms the presence of confounding, and the stratum-specific OR is your best estimate of the true effect.
But if we have many potential confounders, stratification becomes unwieldy, which forces us to use multivariable analysis.
Yes. Multivariable analysis, typically using regression models like logistic or Cox regression, is a statistical adjustment technique that simultaneously accounts for the influence of multiple potential confounders. This allows us to estimate the independent effect of the exposure while holding the influence of all the identified confounders constant.
And this is standard practice now.
It is standard practice in almost all complex epidemiologic research today.
Let's use the alcohol and coronary heart disease, or CHD, example here. An initial crude finding shows moderate alcohol drinkers have a lower risk of CHD, so an RR less than 1.0.
That association may be real, but it is almost certainly strongly confounded. And why?
Lifestyle factors.
Because moderate drinkers often have higher SES, better access to healthcare, and tend to smoke less than heavy drinkers or abstainers. Smoking, high SES, and a good diet are all independent risk factors for CHD. So without performing statistical adjustment multivariable analysis to account for smoking and SES, we would wrongly conclude that alcohol is a powerful cardioprotective agent, when in fact it might just be a marker for a healthier lifestyle. An indirect association caused by confounding.
So we've established that these errors are systematic.
Yeah.
What is the final tangible consequence for a study that fails to control for them adequately?
The primary consequence is the systematic destruction of internal validity. The study loses its ability to accurately reflect the true relationship between exposure and disease in the study population.
So the results are just wrong.
They lead to the systematic overestimation or underestimation of the true relative risk or odds ratio.
And if the internal validity is compromised, the study findings are essentially useless.
Precisely. They create spurious associations that waste resources. If an uncontrolled bias leads to the adoption of an ineffective public health policy, the consequences can be enormous. Understanding the potential for the healthy worker effect masking a true risk, or recall bias inflating a perceived risk, it's necessary to assign the correct level of confidence to any scientific paper you read.
Now, for the listener, an MBBS student, the immediate relevance might feel a bit academic, but it's deeply clinical. Why must every future doctor be an expert interpreter of these epidemiologic findings?
Because medicine is no longer practiced solely based on personal experience, it is evidence-based. You have to be able to critically interpret the results of drug trials, evaluate the effectiveness and necessity of new screening programs, understand disease outbreaks, and advise your patients on risk factors.
It's a core competency.
It is. If you cannot spot the difference between differential misclassification and a true causal effect, you risk basing a life-altering recommendation on flawed data.
And the risk isn't just misdiagnosis, but public distrust. The example of public concern over vaccine safety is a perfect illustration of what happens when correlation is mistaken for causation.
Oh, misinterpretation of associations in public health is incredibly dangerous. Imagine a scenario where a large-scale immunization program is implemented, and subsequently a rare neurological condition is reported.
Okay?
If researchers rush to attribute the condition to the vaccine without first rigorously controlling for age confounding, seasonal variation, or selection bias in reporting adverse events, the resulting panic can lead to the withdrawal of life-saving interventions.
So epidemiology provides the critical intellectual defense against those flawed causal claims.
It absolutely does.
Let's try to tie it all together with that integrated example we introduced earlier.
Yeah.
Analyzing the common cross-sectional finding that people who take vitamin supplements have lower overall mortality.
Okay, step 1, association. We observe a statistical association. Supplement users have a statistically lower mortality rate, so the RR is less than 1.0.
Step 2, analysis of threats. We immediately suspect bias and confounding. What are the primary mechanisms distorting this relationship?
The major threats are healthy user bias and related confounding. People who choose to take supplements are a highly self-selected group.
Right.
This group is inherently healthier. They tend to have higher income, higher SES, they exercise more, they smoke less, they consume more fruits and vegetables, and they're more compliant with medical advice in general.
So the exposure, the supplement itself, is merely acting as a marker for a whole cluster of protective behaviors and high SES.
Exactly. The observed protective association is almost certainly indirect and non-causal. The low mortality is explained by the confounders, the diet, the exercise, the SES, not by the pill itself. The healthy user behavior is simultaneously associated with the exposure, taking supplements, and independently associated with the outcome, lower mortality.
So step 3, causality. Given this design and these threats, can we establish causation?
Absolutely not. The association is just too vulnerable to confounding and selection bias. To establish a true causal link, we must move to a much higher level of evidence.
Take RCT.
We would require a large, long-term, well-controlled, randomized controlled trial where those healthy behaviors and SES factors are distributed equally between the supplement and the placebo groups by chance. Until that RCT shows efficacy, the association remains non-causal.
This systematic approach, from the initial finding to the final causal judgment, this is the epidemiological process. It's really a roadmap for interpreting all medical literature.
It is the intellectual scaffolding you need. Step 1. Start with the association, which is usually generated by observational studies like case control or cohort designs. This generates your hypothesis.
Step 2. You quantify the magnitude and direction using the RR or OR, which gives weight to the finding.
Step 3. This is the hardest work. Rigorously consider and eliminate the alternative explanations. Systematically rule out chance. Check for the presence and impact of bias, both selection and information, and identify and control for key confounders using stratification or regression.
And then step 4. Once the relationship is statistically adjusted and as free of systematic error as you can get it, you evaluate the remaining link using Hill criteria. Does it pass temporality? Is it plausible? Is it consistent?
Then step 5 is to seek higher levels of evidence. You move from cohort studies up to RCTs where it's possible and ethical.
And finally, step 6. Accumulate evidence. Wait for corroboration across multiple scientific disciplines, from bench research providing plausibility to clinical trials demonstrating efficacy. This whole process, which can span years or even decades, is what moves a mere correlation into the realm of accepted causal inference.
We've spent a substantial amount of time today delving into the nuances of epidemiologic reasoning. This conceptual clarity is absolutely essential. Let me leave you with 3 definitive, high-yield takeaways.
Give us the structured summary.
First, remember the core difference. Association is a statistical link. Causation is a judgment call based on comprehensive epidemiologic reasoning, guided by Hill's criteria and biological plausibility.
Second, the one principle of causation that is completely non-negotiable.
Temporality. The exposure must precede the disease. If a study is inherently unable to establish temporality, its causal inference is automatically invalid. End of story.
And third, the 2 primary categories of systematic error and the primary threat from a third variable.
Right. Biases, so selection and information, are systematic errors introduced by the study methodology that threaten internal validity. Confounding is an extraneous variable that distorts the relationship and requires specific analytical control methods like matching or stratification.
And remember the distinction.
Remember the distinction. You adjust for confounders, but you should never adjust for mediators.
Understanding these concepts is not just some academic exercise for an examination. It is truly the foundation for accurate clinical decision-making. You have to be able to recognize a study that's flawed by Bergson's bias or differential recall bias, just as you would recognize a pathological finding on a slide.
Indeed. Now, consider the last clinical guideline or drug safety announcement you read. How robust was the evidence that was presented? Was the association truly causal, or was it potentially inflated by selection bias, or maybe masked by uncontrolled confounding? The strength of your future practice really rests on the rigor of your answers to those questions.
The critical framework to carry forward. Thank you for joining us for this crucial deep dive into the pillars of epidemiologic thought. We will see you next time.